Thank you, Diego and chairpersons. Again, for the question that Habib has asked me, one-word answer, not in, or two-word answer, not infrequently. So because this is something, and I have a slight difference into the algorithm that Alan McNabb wrote. And the difference I do in my lacrimal drainage practice, which you have seen, is after you've done whatever you're doing, put a fluorescein dye disciplines test in, I do not do a lacrimal irrigation. They have a nasal endoscopy after that. You really want to see what's going on in the inferior meatus, middle meatus, and then and only then, if you don't see dye, then I perform a lacrimal irrigation, and my punctum of choice also is the upper. You're absolutely right. I'm also a straight guy. Anyway, so I've been tasked to talk about a little bit about lacrimal drainage system tumors. I bring you greetings as well. And when you talk about the lacrimal system, I have patients and residents who come and say, oh, this guy has got a lacrimal pathology. But what lacrimal pathology are you talking about? Are you talking about a secretory pathology, or are you talking about a drainage system pathology? And that's actually something in between. That's where the ocular surface comes in, which David's beautifully taught us how to be a proper ophthalmologist. You don't have to be a dacryologist to evaluate these patients. So I'm not going to talk about the lacrimal drainage, the secretory system, but I'm going to talk about pathologies, tumors of the lacrimal drainage system as such. This part of what I'm talking about is in the chapter of Muhammad Javed Ali's book. So if you guys do any aspect of tearing and dacryology, you should buy this book and read it. I don't have any financial interest in it. Lacrimal drainage system tumors can be classified into either primary pathologies or secondary pathologies. Yes, we are used to seeing all these squamous invasive carcinomas of the eyelid and the conjunctiva going into the lacrimal system. These are secondary tumors. There's a term called melanoria and treatment talking about where ocular surface neoplasms kind of migrates in the lacrimal drainage system, then seeds in the lacrimal drainage system, causes a secondary obstruction, not a primary melanoma or those kind of things as well. And very rarely you can see metastatic tumors as well. But what I'm going to talk about are primary tumors itself here. And you can see how, like the orbit, the lacrimal drainage system is practically surrounded by non-ophthalmological structures. And that's where you become a complete ophthalmologist by examining the nasal cavity, the paranasal sinus, so on and so forth. So this patient was operated by a very, very senior colleague of mine, a young 20-year-old Chinese male. And I say male, I'm not trying to be a sexist, who don't really typically develop and acquire primary acquired nasal lacrimal duct obstructions. Classic example of the medial canthal swelling, put your finger there, pus comes out, Rhoplast test positive, has a nasal endoscopy, except for a deviated septum, nothing really happens. So it's readily scheduled for an endoscopic DCR. And when they're doing an endoscopic DCR, they open up the sac and they find something inside. A very friable mass, sent off for pathology, you don't know what it is, and comes back as an inverted papilloma. This is actually a very common condition, common in the differential diagnosis of nasal pathology for ENT surgeons. We dacryologists are not aware of it, but actually the nasty thing about this condition, although it's histopathologically benign, is relentlessly progressive and can even have a malignant transformation, especially if you go on and radiate these patients and cause a malignant transformation. So this is one of those things. I have cases which have gone all the way to the skull base and even invaded the anterior cranial fossa just from an inverted papilloma, which is not primarily managed very well. So this is then after the DCI ends up having a pathology and you discover this wonderful tumor. What does it tell you? Actually, we are doing a lot of DCRs blindly without knowing what's really going on. Principles of management of radical excision recurrences are very, very common if you don't completely excise it the first time, and beware about radiation. Here's another patient who also is referred, and this is my fluorescent dye disciplines showing you literally the anatomy of the outline of the nasolacrimal duct, seen as an overflow of the fluorescein right over there. All you have to do is listen to what Javed has said. Put your finger on the patient after the history is taken. You can feel something's not right. It feels a little lumpy. You can get a partial regurgitation of pressure of the lacrimal sac, and that outline I've harted out is where the induration was. So with that in mind, you immediately don't subject them to, remember the word, I used lacrimal irrigation, not lacrimal syringing over here. And there was a upper and lower distal canalicular obstruction as well. We try to attempt to get into the lacrimal sac because sometimes external masses can be impinging upon the lacrimal drainage system. So there was a lacrimal outflow obstruction and a felt mass. So it ends up having an imaging done, and you can see both on the coronal axial is right in the lacrimal sac fossa, and in the sagittal image, right, you see over here is infiltration along the nasolacrimal duct. Okay? another lacrimal drainage system pathology itself. So what did I do? Dr. Richard, you are here. Fine needle aspiration biopsy. Here I used the lacrimal cannula itself, a blunt straight cannula, went through the punctum because I knew there was a pathology in the sac. With the same cannula, I made multiple passes, squatted on a slide, and lo and behold, I had a diagnosis of a carcinoma, squamous cell carcinoma, in 2 minutes in the clinical side without doing any other fancy investigations. So because it was involving in traditional treatment in the past was all about exentrating because you have, as you can see in the MRI, significant orbital involvement. He needed an exentration. I counseled the patient for exentration, but I felt there was a nice clear cleavage plane of dissection that you can get to. So I went ahead, did a dissection, found the plane, did representative biopsies of the medial rectus and the inferior rectus and the orbital fat, no tumor whatsoever, just did a complete dacrocystectomy with a lateral rhinotomy, a Weber-Ferguson approach, did an inferior orbital bone excision, medial orbital bone excision, even biopsied the intraorbital neurovascular bundle, no tumor there at all, and ended up reconstructing it with a flap so that you avoided an exentration, you can do a complete excision. This is how we used to do it in the past. Okay, so the take-home message is the primary tumors in the nasolacrimal duct system, although rare, you don't want to be missing as an oculoplastic surgeon in ophthalmology practice itself. Remember, anything at or above the medial canthal tendon is probably not a dacryocystitis. It should be a low threshold for imaging these patients as well. Epiphora and dacryocystitis are classic protein symptoms which can be present. Remember, sometimes you can have intraluminal tumors. Still, you can squirt fluid around it. So it does not rule out, just because you syringe doesn't mean that you can rule out an intraluminal obstruction itself. And very rarely you can see other pathology itself. So these are the common symptoms. Mass presentation is only about 40%. So you don't have to have a mass as a clinical presentation. When you have it, a lot of these patients have recurrent dacryocystitis. So if you look at the plethora of various pathologies, there are only 2-3 things I want you to keep in mind. Inverted papillomas, which is associated with the respiratory epithelium that you see in the lacrimal system area, squamous cell carcinoma and transitional cell carcinomas, and finally lymphoproliferative lesions, which are not uncommon right over there itself, and secondary tumors. So quickly, principles of management are dacryocystectomy with maxillectomy. If it's breached all the fat tissues into the orbit, you have to do an orbital exentration and usually followed up with the radiation itself. And remember in mind that incomplete excisions result in a lot of recurrences. So last case I'm going to show about what has recently changed. 55-year-old male goes to an ophthalmologist with tearing, and what does the ophthalmologist do? Prescribe artificial tears. And this I see always, all the time. He has persistent symptoms, and then he has a fullness with a nasal obstruction, then goes to ENT surgeon who does a biopsy, and following which is referred to an oncologist who referred the patient to me for an exentration. And we do an endoscopy, you can see that the lateral nasal cavity is not normal. There are some mass lesions right over there itself. This is the patient who now comes to me. What you see in the upper lump is above the involving the medial canthus, above the canthal tendon. What you see the lower lump is actually the lower, below the medial canthal tendon. So it's involving the medial part of both the upper and lower medial eyelid with induration and overlying ulceration itself. Imaging is done, shows a humongous mass lesion, typically in the lacrimal sac fossa. What you see as opacification of the maxillary sinus as secondary mucocele itself. And again, this patient was referred to me for exentration. An MRI was done, which showed the same features right over here, extensive inflammation. MRI tells you mucocele versus tumor itself, a large tumor with significant orbital invasion. Treatment of choice, exentration, craniofacial resection, so on and so forth. So what we did for this patient was actually adopt something different. Because it is a squamous cell carcinoma, I do retinoblastoma practice. Here we actually manage this patient with a neoadjuvant chemotherapy. After cycle 1 and cycle 2, you are now able to shrink the tumors to such a small size. You don't have to do a wide resection. Believe it or not, after doing a chemoreduction, you can see almost complete disappearance of a carcinoma tumor. I'll just take about 10-15 seconds if you don't mind, Diego. So after we've done a chemoreduction, we went and did a localized excision, did all the margins were negative, and reconstructed him. He's kept the eye, he's kept the orbit, the stainless steel wire you can see is for telecanthus correction, and the titanium plate to reconstruct the orbit. So in summary, I think lacrimal sac tumors are challenging. If you don't think about it, you will probably miss it. Be aware of it's present. Be aware of the entire spectrum of pathology. Adopt various ways of biopsying it. Nowadays, I actually biopsy lacrimal sac through the punctum and canalicus and not through skin incision anymore, and tailored approach to the patient. I'd like to bring to your attention an NUH ocular surface and dacrylology symposium we are organizing this October. First, second, and surge, cadaveric dissection, live surgery. Javed Ali and several experts are coming in, and I invite you all. Thank you very much.